for that lovely introduction. I am excited to be here. This is an exciting time to be talking about this, not just because of the month, but because of the content. This is something very near and dear to my heart, and I have learned things in researching this after the topic was, I was voluntold that I was going to talk about it. And I have learned so much. It's been such a wonderful experience for me to see my blind spots and to see us as providers and us as healers and what we can do to move forward to promote everyone's optimal well-being. So I'm going to dive right into just an introduction of myself. I'm a physical therapist, a pelvic floor physical therapist with many, many years of experience in the same hospital system. So I've worked 21 years in a hospital system where I've done acute care, I've done outpatient rehab, I've done inpatient rehab, I've done wound care, and for the past 8 years, I've done pelvic health. And so I'm an outpatient pelvic health therapist. So I see a lot of ladies who are pregnant. I see a lot of ladies postpartum, but usually it's in the 6+ weeks postpartum. And so in January, I had an interaction with an acute care therapist from the other side who contacted me at home and told me that she had a patient who was admitted with a high-risk pregnancy. She was in terrible pain. And this acute care therapist is lovely and wonderful and highly skilled. And she's like, Christi, I don't know what to do with her. And so she and I talked a lot over the course of the week that the patient was there with her. And I talked through things that she could do with her because I was within our system not allowed to go over and provide any services myself, which was a problem that I'm working on too. But the patient got the care that she needed. She was referred to our outpatient clinic, and it was a debacle and a disaster with her getting back into our same system for outpatient care. It involved having to go through, high-level management to be able to just get her back in after she was discharged from the hospital. She lives in a rural area and had been just very recently identified as a high-risk pregnancy. Gestational diabetes was insulin dependent, but that process hadn't even been started yet. And she went into preterm labor at 33 weeks. So she was admitted through our obstetric hospitalist ED and admitted to our labor delivery floor. So after she was discharged back to the rural setting, came in to see me as an outpatient. I saw her one time, and I knew that I had to make that time count. That was probably the only time I was going to see her, and it was. I saw her on a Friday, and she delivered on a Monday. She had a very, all of us are individuals. Her needs were unique, and the needs that she had, in the hospital, out of the hospital, back in the hospital, were specific to her. And she had many, many risk factors, not just as a high risk pregnancy, but as a person who needed to go back to work full time. She's a single mom. She lived in a rural area with difficulty accessing care. She had uncontrolled pelvic pain when she was an inpatient and back pain when she was an inpatient. She had diabetes. And so she got the care that she needed. She got the care in outpatient, but it was taxing and it was not ideal. So I learned from this that our healthcare systems, I think, a lot of them just break down in the normal course of operations, and we fail to provide just the basic services to pregnant and postpartum patients. And that is contributing to the maternal health crisis that is so prevalent. Maternal morbidity is soaring. Maternal mortality is devastating. These deaths are preventable. The importance of perinatal mood disorder identification and management is critical to reduce mortality if the leading cause of death in women postpartum is suicide. And those are recent horrifying metrics about what is a public health crisis. So I was I was assigned the task of researching and finding out more about perinatal mood disorders. And so Rebecca was able to connect me with someone who has a specialty in perinatal mood disorders. Her name is Amanda Hall. And so she had a lot to say to tell me more about what we could do to improve access to and care of pregnant and postpartum patients. But before I go there, I'm going to talk some more about my patient who brought me to this moment. So I've talked a little bit about the patient's course of care. I did not say that on that Monday when she delivered her baby, she was 34 weeks. She was in labor for second stage of labor for 18 minutes, had a 3rd-degree tear. Her baby went to the NICU for 2 weeks. Of course, the patient discharged the day after her delivery. She did see lactation before she was discharged, and then continued to see lactation, came in to breastfeed the baby in the NICU, traveling an hour each way. So she had a lot of risk factors to have some bad outcomes and need extra care, easier, not harder, not less. She was seen by OB 7 days postpartum. Her BP at that 7-day visit was, it's not something that would be a red flag marker of someone who is in a hypertensive crisis, but was an otherwise healthy lady. So we don't even know what her baseline was because it wasn't documented anywhere. They did not check her blood glucose. So her vitals at her 7-day postpartum visit were not terribly troubling, but of course they weren't anything that showed what she was doing with exertion, going to and from the NICU, breastfeeding her baby, being able to get, in and out of cars. Her blood glucose was not checked. She had gestational diabetes. Her blood sugar was not even mentioned. She complained of bilateral leg swelling and was, told to come back if she needed anything. She returned to the ED the following week with severe abdominal pain, and was diagnosed with gallstones, gallbladder disease, and she was discharged again with a referral to a surgeon, which to my knowledge, she never followed up with. She was contacted by us to ask if she had any public health needs that we could try to address with her. And she reported that she felt fine. She had no needs, no pain, no issues. At her OB visit, postpartum at 6 weeks, she denied any pain, any bowel or bladder dysfunction, but she also declined a pelvic assessment, saying that she felt fine. She had a 3C obstetric tear. At 6 weeks, I'm not sure that anybody feels fine. And if they did, they probably wouldn't even hesitate to have a pelvic assessment. It's pretty common practice for postpartum. So that worries me too. She is a mom of color, and I think for good reason, may have had a lack of confidence in the healthcare system. We didn't take the best care of her. I think that the literature reveals that there's elevated fear and distrust in moms of color. Perinatal mood disorders and maternal mortality is skewed toward moms of color, and there's a triple death rate in moms of color, and that's enough to make me feel like I need to lie down. That's a horrifying thing, and that's across with all other factors being eliminated, triple the death rate. I think that it's obvious from my patient's story that providers can be hesitant to acknowledge symptoms, and that feeds into that system of distrust and fear and the stigma of that new moms feel about, or that moms feel about having a place in healthcare. So we have to do better. I think that something that was really important for me to realize is that we all as providers need to become better informed about unconscious bias and normalized bias in our healthcare system. It's on us as providers who care about the moms that we're taking care of to advocate for them, to advocate for maternal wellness within the hospital system where I am, the hospital systems where you all are, within medical teams. We need to be highlighting the disparity in access to healthcare and responsiveness to health needs with pregnant and postpartum women of color. That patient that I saw one time has changed my life and the course of my career. I have not stopped thinking about her, and I worry about her every day. The risk factors that she presents with put her in an elevated category for risk of loss of life. And that is a very sobering thing. And that indicates that we need to pay better attention to the people who are most in need of care. 1 in 4 moms experience perinatal mood disorders. And so because of those kind of numbers and the personal experience I had with my patient, I had to talk to Amanda Hall, who is an occupational therapist. Let me go back one. She's an occupational therapist in Canada. I had a lovely conversation with her, lots of information from her. She has her own clinic. She also is certified as a perinatal mood disorders specialist through Postpartum International. So I learned wonderful things about Postpartum International. The reference for that is at the bottom of the page. They go through most of the information that I'm going to tell you tonight about perinatal mood disorders in lots of detail, and I learned a lot about it. The first thing that I learned is that that perinatal mood disorders are very common, very treatable, and how we can use that knowledge to approach intervening with new moms. So post-traumatic stress disorder is the one that stands out to me the most because of the traumatic nature of my patient's experience. I'm not really sure how someone could not have PTSD after the things that she has been through. So I'll talk more about that in a minute. Bipolar mood disorders in the pregnant and postpartum population, types 1 and 2, depression during pregnancy and postpartum, we hear a lot about, but I don't know that we have the best information about it. Anxiety during pregnancy and postpartum OCD, which was new to me, and postpartum psychosis, I did know about, but I didn't know enough about it. So I learned a lot more, so I'm going to share that. So PTSD is specific to delivery for sure. So it's related to and directly occurring with delivery, a direct result of, but it may coexist, of course, with prior trauma because many of us are walking around with prior trauma of all sorts. So it's superimposed on other trauma. About 9% of women experience postpartum PTSD following childbirth. And most often this illness is caused by a real or perceived trauma during delivery or postpartum. And any perceived trauma is a real trauma. Birth traumas can include many things that we think of immediately, many things that we think of as being not necessarily traumatic in nature that are. Prolapsed cord, unplanned C-section, how many of those are there? So many people are finishing their birth experience and saying, this is nothing like what I thought it was going to be like. And there is a loss and a shock with that. Birth traumas can include obstetric deliveries with VACs or forceps, the baby going to the NICU. Just generally feelings of powerlessness, poor communication, lack of support during delivery, all of which are mitigated tremendously with a doula as they mitigate everything. Women who have experienced trauma such as rape and sexual abuse are at higher risk for developing postpartum PTSD. Birth traumas can include the things that we think of when we think about high risk pregnancy and complicated delivery and complex postpartum characteristics, severe postpartum hemorrhage with or without hysterectomy, severe preeclampsia, 3rd and 4th degree tear, or cardiac events. My patient hits a couple of those, and that's hard to think that she might not have that support that she needs now. Symptoms of postpartum PTSD might include re-experiencing of a traumatic event, flashbacks or nightmares, avoidance of stimuli associated with the event. And whenever you're talking about birth trauma, it's really tough to avoid stimuli associated with the event whenever that event is somebody you've got to keep alive and feed and feed with your body much of the time. And that persistent increased arousal, that sympathetic elevation is real, and it's constant. Anxiety and panic attacks, as well as a feeling of detachment or unreality. So not to be confused with postpartum PTSD, depression during pregnancy and postpartum has a lot of the hallmark traits of depression that we know of from just studies of mental health. But it can start during pregnancy and continue through 1 year postpartum and be considered during pregnancy postpartum. So anger, irritability, lack of interest in the baby, and this is something that's persistent, that's longer than the 2 weeks of the baby blues right after delivery. Appetite or sleep disturbance, crying and sadness, feelings of guilt, shame, or hopelessness, anhedonia, and possible thoughts of harming the baby or oneself. That is possible thoughts that are occasional and related to general sadness, not to be confused with our next category of perinatal mood disorders. Not this one, sorry. In a minute. So anxiety during pregnancy and postpartum also sounds a lot like anxiety that's not related to a perinatal mood disorder. Feeling that something bad is going to happen, racing thoughts, disturbances of sleep and appetite, difficulty sitting still, constant worry, and physical symptoms like dizziness, hot flashes, and nausea, which can be kind of just chalked up by a lot of providers to, oh, well, it's just hormones, just a wash in hormones. So I think probably a lot of times with a lot of these symptoms, they are just being kind of brushed under the rug as, oh, that's just what happens to you after you have a baby, not let us help you with that. How can we help you feel better? How can we help others feel better? So perinatal OCD was a completely new diagnosis for me, but it's a fascinating, also horrifying thing to have to think about experiencing. But it's once you know about it and you know how it operates, and it's not as scary an entity as it sounds like it is. But pregnancy and postpartum OCD involve obsessions that are persistent, repetitive thoughts or mental images, and compulsions where the mom may do certain things over and over again, checking the baby, swaddling the baby, and just having a general sense of horror about the obsessions. Just really is super bothersome, and very, very fearful. These moms are very fearful of being left alone with the infant because they have these obsessive thoughts about harm, and they're afraid of harming the infant. So they are hypervigilant to protect the infant more. And moms with perinatal OCD know that their thoughts are bizarre, and I don't think that necessarily they know that they're unlikely to act on them. This is a terrifying thing to think there could be harm to my baby. I'm afraid something's going to happen bad with the baby with me. So I think that probably a lot of moms are afraid to even talk about it or think about it and share it. And if they do share it, then that ought to be encouraged so that we can reassure that those are very consistent with this diagnosis, which leads me to my next point, which is that we, as therapists, according to Amanda Hall, and she's correct in saying, as therapists, of course, we cannot diagnose any of these perinatal mood disorders. However, we can see signs and symptoms, risk factors, and we can promote self-screening of these perinatal mood disorders to make sure everything is identified, good resources are accessed, good support is given. Postpartum psychosis is an interesting diagnosis, and also a sad and troubling one. Symptoms can include delusions or strange beliefs, hallucinations, feeling very irritated, very hyperactive often. They can go on both ends of the spectrum, from severe depression to flat affect, decreased need for or inability to sleep. Lots and lots of paranoia and suspiciousness are hallmark symptoms, very rapid mood swings, and sometimes just difficulty communicating. Even words are hard. It's super important to distinguish postpartum OCD, I learned from Amanda Hall, from postpartum psychosis. Postpartum psychosis occurs in 1 to 2 out of every 1,000 deliveries. The onset is sudden, most often within the first 2 weeks postpartum, but it can appear anytime in the first year, but it's usually within the first 2 weeks. Postpartum psychosis is the one that makes the news, the horrible news. If it happens, it's going to get on the news. And in that instance, moms are not afraid of harming the baby. They are opposite the moms with perinatal OCD. They are always worried about harming the baby. Postpartum psychosis can result in death if untreated. Perinatal OCD is not a medical emergency, and someone needs reassurance about their concern that they might harm the baby and those intrusive thoughts. That is a symptom of the baby being safe with mom. Obviously, you're going to do extensive screening to make sure that extensive self-screening, encourage and ensure that safety is optimized with this population. But if you have a mom who is with you in your care, and she's terrified, and she expresses concern to you that she has intrusive thoughts about harming the baby. Absolutely, she needs support, but she also needs to know that that her verbalizing that to you and being able to identify it is actually a really good sign that she's taking good care of the baby, and talking about it is the right thing to do, and getting good help and resources. When I was going through this earlier with other Dr. Christi, we talked about the bipolar disorder symptoms and characteristics being pretty consistent of bipolar disorder types 1 and 2 with those that are not perinatal mood disorders. And so I'm gonna gloss over those a little bit. All due respect to the bipolar disorders, got a lot of stuff to talk about with other perinatal mood disorders. So I would just briefly say Postpartum International has great information on the characteristics, and so I did list them briefly here. Back to perinatal mood disorder screening. I say, and Amanda Hall says, and Postpartum International says, and I think that we probably all, if we're here tonight, agree, every postpartum person should be screened for perinatal mood disorders. We should be paying attention to those who are in groups where their risk factors are higher. As rehab therapists, we can't diagnose, but we can offer self-screening and information. And we don't ask because we worry that we're not trained enough, or that we might do more harm if we ask. And neither of those things are the case for someone to be able to help someone access resources to help support them. We can connect and support, and we can enable self-screening. We have screening tools that are available. The Edinburgh Depression, there we go. Edinburgh Postnatal Depression Scale, EDPS, and the PHQ-9 are both available on Amanda Hall's site, as well as on Postpartum International. If any of the indicators for EDPS or the PHQ-9 indicate that someone is falling into the range of the depression, then we are going to follow up with an additional screening tool, the postpartum distress measure, if the scores are concerning. The ranges are here, and if there is any indication that someone is considering harming themselves or harming someone else, that is a medical emergency. You do refer to their emergency contact. You do, which all that's provided with the intake. So if someone has provided their emergency contact information, you are going to be talking to the doctor. You are going to be calling the emergency contact. If neither of those is available, yes, you are going to need to be getting emergency services involved. If someone is in distress and you're able to help them identify that distress, referring them to mental health resources is key. So Amanda Hall also talked to me a lot about Dr. Kristen Neff and her kind of philosophy of interventions. Dr. Neff talks a lot about 3 parts to her approach: more self-compassion and more self-advocacy, just more self-kindness, loving kindness, seeing moments of joy, reflecting kindness, just a big kindness component, and recognizing common humanity. And common humanity is the idea that we all have shared experiences, and that we are not alone and isolated in the sad experiences and the suffering that we go through, that we are connected to each other, and that we are able to help pull each other up and out and into the common experience through connection and community. So treatment concepts, we have patients for a long time when we have them. I mean, it's not long enough for me. I always run over, but you know, if you have someone for 45 minutes, yes, you're absolutely doing all of your interventions, but you're also thinking of treatment concepts like providing resources, as I've mentioned, normalizing experiences, doing active listening to what someone is sharing about their birth story, about their birth trauma, about their feelings, and about their there's just not a lot said by immediate postpartum moms about how hard things are, or how bad she feels, or how lonely she feels. And we know how lonely moms feel whenever they have immediately delivered a baby and all of the attention is quickly shifted to the newborn, and the newborn is well cared for. The question I would say is, what are we doing to take care of the moms immediately? The moms need to be cherished. Teach mindfulness, teach breath work. Amanda Hall loves Breathe Mama Breathe, which is like a 5-minute moment of breath work for moms. The things that we're working with our patients toward achieving more independence with ADLs, with elimination, with sexual function, immediately postpartum, of course, functional mobility, everything to engage cores that have just been through a lot of growing and delivering. These things all strongly correlate with mental health. Being able to feel independent and be safe with the functional activities is a key part of mental health. The things that we're working with people to improve affect all aspects of their daily life. So I like to think of there being a 3-part approach to physical therapy intervention. During pregnancy, I think that every pregnant person needs to see a physical therapist. I think that information needs to be delivered on core stability, on breathing, on delivery information, on bowel and bladder habits, biomechanics, everything that gets a pregnant person in the best space to be able to be healthy during pregnancy and deliver into a state of health. Most importantly, and that informs me the most at this point in my career, is during the hospital stay. And the response that I've gotten from a lot of people are, aren't you an outpatient pelvic health physical therapist? What does this matter to you? What is this? They're not really there long enough to, and they're immediately postpartum. Like, why are you interested and involved in this? There's one thing that this experience has taught me, and that is that all of these things are connected. It's the same person cross-sectionally across all of these areas of the hospital system. So, enacting algorithms that include screening and specific risk factor identification for those who will have potentially maternal mental health challenges, making sure that we have a vibrant acute OB physical therapy plan engaged, having lactation referral and support. All of those are going to be critical things to happen during the teeny tiny short hospital stay that they have, but they're critical. Immediate postpartum care is also critical. I say that pelvic PT needs to be initiated as soon as possible, not for internal assessment by any means, but in weeks 0 to 6, that's a critical time for the mental health of new moms. That's when everything is changing and different, and more is expected of some new moms, first-time moms, than ever of their pelvic floor, of their body, after just going through the tremendous ordeal of delivery. Mental health screening, which I've said over and over again, a birth trauma referral to a birth trauma processing specialist if that is indicated, mental health resources and support groups for new moms. I'm more familiar with the 6 weeks plus interventions because that's what I've been doing. So what I will be doing after that is self-screening now to make sure that I don't miss blind spots with ways to advocate for my patients' best health, best outcomes, best lives. Pelvic PT for sure, especially if an internal assessment is indicated postpartum. If someone has suffered any kind of complications with delivery, that's standard of care. That needs to be standard of care. Teaching proper breath support, biomechanics, abdominal wall, core strengthening and protection, bowel and bladder habits, wellness education. All those things are, part and parcel with traditional postpartum pelvic PT, but I think it's a more progressive approach to take to say, how did we do for you? Take that feedback and inform ourselves how to make it better next time for the next person, and asking very specifically at every point when someone is in front of us, what do you need? One of the things that I love the most that Dr. Rebecca Seagraves talked about in the course is making it customized to what this specific person in front of you, having just delivered a baby, needs to be able to do in tomorrow, needs to be able to do in 3 days, needs to be able to do next week. Are they going back to work? What kind of support system do they have? What other concerns that we don't even know they might be facing? What do you need? A lot of times new moms aren't asked what they need. Sometimes it's hard for them to even come up with it. They know what everybody else needs, their caregivers themselves. What do you need? That needs to be asked of new moms, and we need to be doing a much better job providing that. Here are my resources. And here's my thanks to my 2 kids, 15 and 13, who are Zoomers and who know how to use Google Slides and things like Slides to Go. I'm Amanda Hall, perinatal mood disorder specialist extraordinaire, and Emma Belcher, who is a random college student and lovely person who helped me with a presentation that is out of my depth for technology. So